Hello, and welcome to today's webinar. And thank you very much for taking time out and being here today. I want to introduce myself. My name is Ayang. I am the Marketing and Educational Coordinator here at NeoBiotech. And this is me right here. And hello and welcome again. So today's agenda is very simple. I will introduce our topic and the presenter, and also go over some communication tools. And at the end, I will make an announcement in regard to upcoming webinars and how to receive your C credit. So please don't leave and stay until the end. And our topic today is why do sake preservation with Dr. Mike Chang. And here's some communication tools that we are recommended to use. So the first one is a chat box, and we are strongly recommend you to use this chat box right here to communicate with me if you have any technical issues and other than the topic. And at the end, we will have a Q&A session. So please submit your questions through this Q&A box right here. And Dr. Chen will answer questions. And please be advised that Dr. Chen may not answer all of your questions since we have a short period of time today. And at the end of the lecture, like I mentioned, I will have an important announcement about upcoming webinars and also how to receive your C credits. So please don't leave and stay until the end. And let's have our Dr. Chen speaker to start the webinar. And good morning, Dr. Chen. How are you doing?
Doctors, I hope everyone's enjoying their extended vacation. We're going through this lovely pandemic, and I hope we will get out of this soon. At least California, I think we're going till end of May now, but I think we're going to come out stronger. A little bit about myself. My name is Mike Chang. I've been practicing for about 30 years. I do some work as an expert witness for the liability insurance company. But my major goal, my major things that I do is we do a program with NeoBiotech in Mexico, Tijuana, Mexico, pretty much monthly. Maximum 5 doctors that goes down, and we do live surgeries. And most doctors are very green, and they be learning how to place implants, to do sinus, to do ridge split, bone grafting, basically everything to get your hands wet. Been very popular. Every doctor pretty much will be placing between 15 to 25 or more implants for every trip. It's a great learning experience for doctors that wants to do implants to start or to improve their surgical skill. If you're interested in something like that, please talk to your sales rep, and they can give you more information about that. So let's get started. And let me share the screen. All right. So why do we do socket preservation? This is a general overview. Obviously, there's a lot of information, but I think it's pretty straightforward. My email is drmike@sjimplantdent.com. So later on, if I didn't answer your questions, you have anything that you don't want to ask, please feel free to email me. I'll be happy to return your email. So to get started, obviously we need to know the steps to preserve the socket after we take out the tooth, but we also need to know the different graft materials available that we can use and place into the socket. But bottom line is, why do we want to do it? And when we take out a tooth, not knowing, out of dental school, we take out a tooth, we damage the buccal area, we damage probably the lingual area, the tissue is pulled or torn, and we just leave it open. And then a few months later, you see an indentation on the buccal side, or the soft tissue has receded, i.e. the attached gingiva. And of course, having that type of situation is not ideal if you want to place implant, because you do need the attached gingiva. You do need this volume of bone to support the implant that you're going to be placed in that area. So socket preservation is becoming more and more important. i.e. Gordon Christensen comes in. So in 2012, at that time, he was saying socket preservation is something that's becoming the standard of care, but now it's already the standard of care. And this is something that in basically all office, if we take out a tooth, we need to give the patient the option of what to do in that area. It doesn't matter if you're putting in a bridge or an implant. You want that area to look as normal as possible, i.e. not to lose basically the foundation, the gum and the bone of that site. So we do know with socket preservation, bone grafting, it reduces the loss of bone volume, okay? So obviously keeping the same shape, reduces the loss of attached gingiva. So we know the bone and attached gingiva goes hand in hand, because if you lose the bone volume, the attached gingiva is going to recede and mucosa tissue is going to invade. And obviously, if we have both of these intact, we have a better maintenance of the ridge height and width. So in further down the road, we can place implant. And most importantly, if it's in the anterior area, it's aesthetic, plays a major role. And again, it doesn't matter if it's a bridge or if it's an implant. If it's a bridge to pontic, you want to make it look normal and not look very long. And so the different type of bone defect, obviously today we're going to focus on the extraction site. So what happened after extraction? We know basically you get a clot, a lot of bleeding, you get a clot, and the granulation tissue grows in there. The granulation tissue replaced by connective tissue, and from there you get basically down the road mature bone. But if this area is just left alone after the tooth is removed and you just allow the clot to form, guess what? Most time the soft tissue is going to invade the area much faster than the bone growth into that space. So that's why when you take out a tooth, you'll see, i.e. most time the buccal side where you have the indentation, and it just basically aesthetically is not so sound. So soft tissue invasion is number one that we see. Buccolingual wall resorption. The reason buccolingual wall resorption is because most time the buccal plate or the lingual plate is about probably 1 millimeter, maximum 2 millimeters. So it's very, very thin. And most time when we take out a tooth, something is broken. And that area will get resorption the fastest. And so when that happens, basically you're gonna get an indentation, not enough foundation in that area, and where GBR is gonna be necessary later on if you're gonna be placing implant. So you want to be able to take care of these problems, and patient needs to know that you want to maintain the basically foundation so that you don't have to go revisit the area again. So as a preventative, we want to maintain the normal architect, keeping the gum, keeping the bone, prevent the bone resorption, obviously. And one thing that we don't really talk about a lot, which is the incidental papilla. So when you look at this area, if you don't do anything, and this bone in the interproximal area start to recede, these papilla, little triangle tissue, are going to be gone. And when they're gone, and you want to bring that back, it's very difficult. And also, if you do place an implant, you're going to get a black triangle, and patients are going to be very uncomfortable because food get trapped in there, and aesthetically, it's just not pleasing. So those things has to be addressed ahead of time before you take out the tooth, to be honest with you. So always remember, the rate of healing of soft tissue is much, much greater than the bone growth. So we have to go in there and control the situation so that the bone can grow properly. So Dr. Nevin, in the early 2000s, basically already presented that, horizontally, 30% buccal bone resorption, 10% lingual bone, okay, and vertically, 25 to 30% bone loss. So it's quite a bit when you think about it, and this is something we want to prevent, and we can prevent. So if we do graft the area, basically less than 20% of the buccal plate is lost. And if you don't graft the area, more than 20% of the bone loss will occur. So this is pretty much a no-brainer. We want to preserve the buccal plate, i.e. buccal and lingual. So most noticeable is the aesthetic zone, i.e. it's the upper anterior or the lower anterior. Basically, the buccal plate is very, very thin. So most time when I do implant restoration or immediate placement, I will treatment plant bone grafting in the aesthetic zone, mainly because even if you just place the implant, that buccal plate's only 1 millimeter. And we know we need a minimum of 2 millimeter circumferentially around the implant for good support. And if we don't have that, the bone loss will occur. So the key to socket preservation is any defect, all 4 walls, the alveolar wall has to be intact and has to be have the proper thickness, minimal 2 millimeter if we can. Surgical aseptic, you want to make sure that area is clean, there's no infection. And I put pH next to it because it's something we don't talk about much, is that we know if it's in an acidic environment, when there's a lot of bacteria, its pH is very low, it's acidic. So the body response is not healing. The body response is to invade it with white blood cell to get rid of the infection. So if you are taking out the tooth and you put all kind of stuff inside, i.e. bone graft, and you don't really clean it out, the pH is low, that graft is gone. The body's gonna basically resorb it or basically swell up and you have to go in and take it out. So you got to keep that area clean, you gotta clean it out. And when you clean out the socket, not necessarily just scraping with the curette, but sometimes you might have to go in there with a handpiece and take away the infected bone. Soft tissue closure is important because once you graft the area, you want to make sure that the tissue do adapt and close up as soon as possible. Space maintenance is important because when you graft the area, the bone graft, the volume of the bone graft help maintain the shape and size of that space. If you put in something that is very watery, obviously it's not going to work. So you need something that is good, solid, and that is a little bit dense, but you don't want to overpack it where then the graft is not going to convert to the patient's bone. The very important thing is graft immobilization. We know if that graft material have any type of movement, i.e. 20 micron, that graft is gone. The body's going to reject it. So it's important when we graft, and we need to be able to stabilize that graft material and then allow the body to clot that area and start the healing response. Obviously, the host vascularity is important because if there's no blood, no healing. So we have to make sure this patient is healthy, i.e., no smoking, not an alcoholic. So the vascularity is good so that the patient basically wound can heal fast. Graft material plays an important role. We'll talk about that in a few minutes. And then the transitional prosthetic, the dentures, temporary dentures, flippers, stay plate, the ESSEC temporary. Doesn't matter what you use. Important thing is no pressure on the graft site. If there's any pressure, the graft material is lost. So we go to graft material. Obviously, the first and foremost, the golden standard is the autogenous bone. The autogenous bone is patient's own bone. The body won't reject it. It likes it. It will take it in, and it will convert and solidify into its own bone in that socket area, if I may. So on the right-hand side of your screen, you'll see this auto chip maker, ACM. This is made by Neobiotech. This little gadget is phenomenal. You see this little point here. So what you do is I usually like to go to the angle of the lower jaw or the tuberosity of the maxillary in the back, and I'll make a little incision, open it up, and this little gadget has the point so it doesn't slide. You basically lock it onto the bone, and you have the sleeve that is attached onto this drill, and then you will basically drill, and it takes, give or take, 10 seconds, and you will basically have a shaving of 1 cc of bone. It is so easy, and it's the patient's own bone. And so it makes it much easier for the patient to accept the treatment because now they say, all right, I don't want to use cadaver, I don't want to use animal or anything else. If they can use their own bone, they're actually more happy. So autogenous bone has osteogenesis, osteoinduction, osteoconductive. So this is great. Everything is there. Drawback, I got to do a second surgery. Some patient might not like it. And then limited availability in the oral cavity because sometimes the jaw has a lot of defect and you don't want to go in there and do something like this. But it absorbs quickly. So when you see on the right-hand side, you'll see the sleeve attaching to the drill. This is basically attached to our contra-angle handpiece. So it's pretty cool. Very, very nice little gadget. So if you don't want to use the autogenous bone, then we go to the allograft, which basically is cadaver bone. There's lots of it. out in the market. You have the fresh, you have the frozen, freeze dried. You know, it's just different company. They all make pretty much the same thing, but it does require a lot of processing. Okay, and basically this material comes in different sizes, shape. So you have to choose the one that is ideal for your grafting situation. My personal opinion, I like the particle to be small. I don't like it to be large. I like it to be as rounded as possible, mainly because the more surface area you present to the blood, the clot, the better it is for that material and the faster for it to convert. So in this situation, Verigraft is something that's very popular. It has cortical and cancellous mixture, 250 or 1,000 micron particle size, and basically it can convert between 3 to 5 months. On average, after I graft with this material, I'll go in about probably the 4th month. And when I drill, it's pretty firm. It's a little bit like a hard leather when I'm drilling. So it's very easy with that texture. So the allograft does has the osteoconductive, osteoinductive, but the disadvantage is possible disease, immunorejection, inconsistent qualities, and depending on, per individual cultural acceptance, some people just don't like cadaver bone, mainly because of their religion. So you have to tell the patient what you are using. The next one is xenograft, animal bone. You get it from the cow, from the pig, from the horse, from different kind of animals. This is very osteoconductive. And the nice thing about this material is volume maintenance. What that means is that you have this space. You place it in that space, it's going to maintain that space very nicely. I usually use xenograft, and this is my own personal opinion. I use xenograft mainly for repair. So if I have an implant that has thread exposure, some of the bone has receded, I like to use it as a repair because it will grow bone or it will solidify into bone much faster. Remember, you're regenerating or you're doing repair, and this is mainly a repair where the bone basically solidify and harden. And the disadvantage of this is basically, again, possible disease, immunorejection, but one main thing is inflammatory response. Most time when I use xenograft, I will prescribe some steroid to keep the inflammation under control. And again, cultural acceptance, some people just don't like it. And one of the brand that I use and I like it is this material where the granule, again, you can see 0.25 to 1 in size. It's very, very small, and it's nice. But it has that, basically I call it the scaffold structure, where the blood can basically enter through these maze, and it'll lock into this granule. And it's quite nice. This material, when I drill on it, it's pretty firm by the 3rd to 4th month. But you have to be careful because they do have a tendency of shattering. So I like to use it more for grafting and not for, the final bone graft for the implants. Synthetic bone is becoming more and more popular. And I like synthetic bone a lot, mainly because there's no problem with patient in using it. There's no disease transmission, no immunological response. But the best thing is when I use this in the sinus, as you can see from the x-ray, it's radio opaque. I can see how much bone I place into the sinus. I can see it through the x-ray, from the x-ray, of what the shape, how it is. I can adjust it accordingly if I have to. What makes it nice that this comes in different sizes, different material, in putty, in granule. But the only drawback, I think, for a lot of people, it's slow turnover. Because most time when I use this, I might have to wait 6 months instead of 3 to 4 months. So that's something you have to talk to your patient on what they think. Now, this material called Agua, I really, really like. It is basically, it's a calcium sulfate material, medical grade. What it is it has the liquid and the powder, and when you mix the liquid and the powder together, basically you have a 1-minute working time, and once you mold it and shape it into the area that you need, it will solidify. It does not move. And calcium sulfate has been around for over 100 years and is something that we know will convert to bone. So if the material is immobilized, it's solid, basically it will convert to bone, but it just takes time. And the nice thing about this material, membrane coverage is not mandatory. So if I can have this solidified and locked in, it's not worried about contamination because nothing's gonna seep through. This is really, really nice, and it seems like more and more synthetic bone grafting material is heading to this direction because it has the ability to become firm and hard, so it won't jump around. So now we know there's different materials available, we want to do some preservation in the socket. So the primary goal is I want to do an atraumatic extraction, because we know if I do a traumatic extraction, the body is not going to turn on the healing response right away. The body's going to turn on basically the white blood cell. It's going to invade the area. It's going to try to clean up the area before it will heal. So it's important that we do this as non-traumatic as possible. A lot of time when I do have a traumatic extraction, I actually just tell the patient I'm going to leave it alone for about a week or two, have the patient come back, and then I'll go back in and re-clean everything again. But by that time, you have actually some tissue closing in on it, but most importantly, the inside, the socket, is already clean, and that makes it much easier for you to manipulate it. The socket evaluation after extraction, you want to make sure any granulation tissue, infection is removed, i.e. when you have endo infection and you remove the endo tooth and it's just tons of infection, lots of bleeding, you want to make sure you clean out that socket, irrigate that socket, and when you irrigate, you can use saline solution, Paradex, anything to basically make it as clean as possible. And then use the graft of your choice and the technique to make sure you do it nice and clean and be able to secure the graft material. So primary goal is to visual inspection, make sure it's all clean, palpate, probe, make sure you have nice, solid, fresh bone, tap the area if you have to, use x-ray if you need to. So when you look at this, one of the things that I like to do is I like to use a piezo. The piezo is so much easier, it's non-traumatic, and what I do is I measure the length of the root on the x-ray, and after I know the length, I will take the piezo with basically a flat end tip, and I will go on the mesial and the distal side, and I'll sweep the mesial distal side to break all the PDL. I don't touch the buccal or the lingual because I know if I do, I will break the bone. But the mesial distal is firm enough that it can handle the piezo, and then you get it loose enough, then the tooth will come out very, very easy. So I do all my extraction with a piezo. I put it on wheels so I can wheel this machine into any room. And there's many different type of piezo that's out there. You just have to find the one that's comfortable in your hand. Okay. So again, you want to go on the mesial side, on the distal side, break the PDL, and once the PDL is broken, then you want to be able to go in there with an elevator, okay, and then be able to take the tooth out. The elevator that I like to use is called a Bernard elevator. It's a spade in shape. But the most important thing, make sure you get one that's diamond coated. The diamond coating is extremely important because it's able to get in and grab onto the cementum as you rotate it back and forth on the mesial and distal side. It can hold on to that root and it can start turning it and break the PDL on the buccal and on the lingual. So really, pretty much when you think about it, you need a simple universal forceps to take out the tooth. You need the elevator to loosen the tooth. You need the piezo to break the PDL. And you have those, you can take out a tooth very, very fast and easy. Most importantly, non-traumatic. So most common is when we have all four walls intact, i.e. the buccal plate, which is the most easy one to break. So if we have the type 1, as you know, type 1, you got all four walls. Type 2, the buccal plate is gone. Type 3, you got to do GBR. So we have the type 1, which is the most common. Go through the step in removing the tooth without cutting the soft tissue. If you can keep the soft tissue intact, that means the vascularity is all there. The healing will be very, very fast. And then make sure you clean out the inside with a curette, with a handpiece, and usually I like to use a high speed with a round burr, sometimes flame shape, whatever is necessary is that I can make sure I get a fresh surface of the bone exposed. And then graft of your choice. If you can do autogenous, that's great, but most time everybody's gonna be using cadaver or synthetic material. And then you want to loosely pack, not densely pack. The important thing is you wanna make sure the bone graft and the blood are mixed, but there's enough spacing so later on the capillary can grow through to these open space and start converting the graft material. And then of course, you have to place a membrane or sometimes using a collagen plug. Most time when it's an anterior single root or bicuspid 2 roots, I like to use a collagen plug because it's easier and it is smaller in the diameter and size, and it can cover it very nicely. But sometimes with a molar, I tend to use the membrane, and the membrane help, you have to make sure you shape it well that it will tuck underneath a little bit into the buccal and the lingual, and then when you suture it, it will secure the membrane in that position. So I'll go in there, I'll make sure I place the graft material all the way up to the crestal area, knowing that this is where the bone I want to be. I want the healing all the way up to the tip. I don't want this to shrink. I want to keep it where it is. But before I do that, always irrigate, always clean out the socket, make sure there's bleeding. Don't put the bone graft in there when it's no blood, otherwise you will get dry socket. In this picture, when you look at this picture, what is the mistake in this picture? The main thing is you see this little dark area. The graft material only was in here, but not in the here. So later on when it heals, I might have a little defect on this spot. So that's not good. So it's important that after you finish all your work, take an x-ray, see where you are. And usually what I like to do is after socket placing the graft material, I will take an x-ray and see, make sure everything looks good. Once everything looks good, then I'll suture everything together. This basically summarizes it. You have a tooth that has an infection that needs to be removed. You extract it, you curate it, and when you remove it, we're lucky enough to take it out in one piece. You can see the cyst that's involved. Obviously, you gotta go in there, clean, irrigate, and once you do that, graft the area, and then you have a good amount of bleeding. Make sure the bleeding is controlled and stop, and the clot form, and then you place your membrane or collagen plug over it and then suture. So when you suture, again, you want to make sure you can secure the membrane in place and nothing falls out. So one of the things we like to use is horizontal mattress type suture. Some people like to use interrupted, but it really doesn't matter what you use. The main goal, whatever you do, make sure this membrane stay in place and the suture don't come apart in 2 weeks. Most time you want to remove the suture maybe in about probably 4 weeks. In the suture of choice, obviously, if you use silk, 4 weeks, it's going to have a lot of plaque on the suture. So silk is not the choice. I like PTFE because this is non-resorbable, it's monofilament suture, it's smooth, it's comfortable on the patient, easy to use, very strong and pliable, and handles well. But most important, the knot security is great. It doesn't come apart as easy as a lot of other suture that's available. So I like to add even one more thing. I like to use periodontal dressing, and I'm using this more and more and more, mainly because we have a lot of patients that's out there that, you do all these kind of surgical work, but bottom line, they don't keep the area clean. When I put a periodontal dressing on there, the periodontal dressing, most importantly, is bactericidal, fungicidal, and it closes up that wound. It seals it. So the patient said, you tell him, don't go drinking or don't go eating spicy food. If they do, it's not going to get into that wound site. It's going to keep the wound site clean and won't contaminate it. It protects the area. So it's important that now, I mean, obviously anterior-wise, it's difficult to do because it's aesthetic, but mostly on the posterior, you tell the patient what you're going to be doing. My patient has no problem with it. And they actually prefer it because they feel that with that on and sealing up the site, they can live a normal life for the next few weeks. So they're okay. Now there's a few products that's out there. These are the common one. You have the non-eugenol based hand mixed dough-like. This is the most common one that we use. You have this one, the Barricade, which is non-eugenol too, but it's light cure. It's very rigid. Then you have the Perio Care, which is also non-eugenol based. It's hand mixed, and it's very elastic. And this material actually is quite good. Co-pack is good, but it does chip and falls apart. This is Barricade is too hard, I think. But again, you have to test it out and see which one you like best. So in this instance, I have to take out the molar. The molar is removed. Oops, I'm sorry, let's go back. The molar is removed, bone, clean it out, bone graft is placed, and then we cover it with membrane, but then we use the periodontal dressing. And you can see I tucked it into the interproximal area because that allows me to basically secure this material and it doesn't come apart. You want to be able to keep that in there for at least 1 to 2 weeks if you can. Ideally 2 weeks. I think that works out best for the patient. So a dry run. Got a tooth number 8, hairline crack, sensitive to pressure, and patient can't do implant right away, so socket preservation is recommended. Go in, take out the tooth atraumatically with a piezo and with a Bernard elevator, keeping the soft tissue intact. Cleaning out the area, scraping it, handpiece is sometimes needed. Make sure there's no granulation tissue in there. Saline, Paradex, whatever you like to clean it out. And once you have it all clean, make sure there's some bleeding in there, and you start packing with bone, not too tight. And then sometimes we like to mix the graft with antibiotics. In the old days, we like to use tetracycline, and actually tetracycline still works very well. But some people like to now mix it with clindamycin or cliacin or other antibiotic material of their choice. But importantly, you want to fill it up all the way to the crestum. And then after that, membrane of your choice or collar plug and the tissue should basically wrap over it. And then you want to suture so there's no bone exposure. And again, over here, you see there's a horizontal mattress suture. You can use any type as long as you can secure it. And once you secure it, keep the area clean and basically probably keep the suture in there for about 4 weeks. Now, ice cream cone technique. I'm sure many of you have heard of that. This is basically used and started by Dr. Tarnoff. What it is that when you do a class or type 2 defect with basically a buccal or a lingual, a one-word defect, again, you atraumatically remove the tooth, clean out the socket. Once it's all cleaned out, you take a collagen membrane, a resorbable membrane, and then you want to cut it into a cone shape, an ice cream cone, and that's where the term comes from. You cut it into an ice cream cone, and then you will insert it inside the socket, not outside, inside the socket where the defect is. Fill it up with the graft, and the upper portion is folded over the socket, and then you suture. What happens is over time, this membrane will start to resorb, and once it's resorbed, the wall is created with the help of the graft. So you have a tooth that is damaged, and we remove it, and once you remove it, we see there's a lingual defect, not a buccal, but there's a lingual defect. So we go in there, we place the ice cream cone membrane, graft the area, and then over here is doing basically a continuous, and then suture it up, take an x-ray to make sure it's all filled in. This is the minimally invasive procedure, no flap, membrane to prevent soft tissue migration, small particle. Tarnoff likes the cancellous freeze-dried allograft. It really is your choice of what you like to use. And this is basically a basic guided bone regeneration. So in general, the buccal plate is usually thin, millimeter, 2 maximum, but usually about millimeter in the anterior. And they're prone to basically resorb first because they're so thin and they're weak. So it is important that when you see something like that, you do want to do preservation of the alveolar ridge. Or even if you do, let's say, immediate placement, you want to graft the buccal. You want to make sure that bone thickness is minimum 2 millimeter or more. So the code for ADA code is D7953, bone replacement graft for ridge preservation. This is the code we use. But you have to remember also, i.e. like Delta, they don't allow extraction and socket preservation together. You have to build them separately. But most insurance companies do allow it to be done together. So that's pretty helpful. So bottom line is we need to educate our patient. We need to basically tell them the first year how much bone is lost if you don't do anything. But it's not just the bone, also the attached gingiva, the hard gum, as we can tell them. And then by doing the socket preservation, we reduce the need of future GBR, okay? And this is stress because in the aesthetic zone, it just makes it so much nicer when we have everything intact. And long-term wise, it's a great investment. I think patients don't understand about bone loss, but when we explain it to them, they see it pretty clearly. So socket preservation, technique is all dentists can do it. It's not something fancy. It's pretty straightforward. Well, that concludes the lecture. I think we have time for Q&A. So I'm going to stop the screen sharing and we're going to go to the Q&A. And let's go to Q&A. All right. Let me turn on this side also too. Okay, the question is, do you recommend to always use a membrane after socket grafting using mineralized or demineralized bone? Why? Okay, membrane-wise, I think it's helpful, but if you use something like Agua, I won't use membrane. I just place the Agua in there and then make sure it's hardened. Once it's hardened, I'm done. But I'll still put a suture in there just to make sure the tissue wraps around it. As far as mineralized or demineralized bone, I use both. I really don't see the difference, so it really doesn't bother me. I more or less, buy what's available. So I don't have a problem with that. The next question is, can you drill through synthetic bone with implant placement? Absolutely, 100%. You just have to give it time. So when you use, let's say, a calcium sulfate, I like to give that at least 4 months to 5 months before I drill on it. And when you do drill on it, it is drilling on patient's own bone, not the synthetic bone. Most of the synthetic material, it's already converted. For most part, synthetic material, calcium sulfate, or ceramic material, they will be around the body probably 10 months or 12 months maximum. But by the 4th month or 5th month, pretty much 50% of it's gone already. It's already converted. So yes, I definitely will drill. I will do that. What happens if I don't do coverage? Well, if you don't do coverage, you just have to make sure you achieve primary closure. Because if you don't do coverage over the socket, the graft material might fall out. If it's in the chewing area, it will come out. So you want to protect the graft material. Another question, some authors said no coverage is needed if we have all 4 walls. I disagree with that. I really recommend that if you can get primary closure, that's great, but most time you don't want to disturb the vascularity of the area. So I will take usually a collagen plug, and place it over it and suture the whole thing, and that will help it quite a bit in securing it. And then obviously, if you don't want to cover it, use a periodontal dressing. That will help too. Something to secure it. You want a peace of mind. Remember, the patient don't remember success, but they will always remember failure. So you don't want to have any failure. You want to keep this, as simple as possible, as straightforward as possible. The next question is, usual base periodontal dressing could affect bone grafting because it can reduce bone growth. That's right. You're totally correct. That's why you want to use non-eugenol. I don't like to use, plus also the eugenol base material is very uncomfortable to the patient. It doesn't taste good, and it's very, very warm. So yeah, definitely don't use it. Next question is, I find that if any of the resorbable collagen membrane is exposed in the oral cavity, it tends to break down. If you can't get primary closure, I use more PTFE, non-resorbable, but it tends to irritates the tissue. Doc, you're totally correct. That's why I like collagen plug. That's my own personal opinion. But with that being said, when I do use a collagen plug in the posterior, I will use periodontal dressing. I actually do periodontal dressing quite a bit, if I may say that, because it just makes things so predictable. And that's what I'm looking for. The PTFE, it's great, but it is a little bit irritating when you have a large piece of PTFE touching the soft tissue. Next thing, can you go over suture technique? Not in this lecture because I don't have enough time, but absolutely we can put together a webinar on suture technique, because I totally agree with you. Suturing is extremely important. Actually, good suturing will give you great success. Poor suturing, doesn't matter what you use, will give you poor success. Another question is, what membrane you prefer for open membrane technique? I don't understand that question, but basically the membrane is used, or collagen is used the plug is used to secure the bone graft. The bone graft should be mixed with blood and you achieve a clot. I don't let the patient leave the office until I see some form of clot form, because if the clotting factor is not there, everything's going to come apart. And then with the membrane, I choose basically, if it's a molar area, obviously collagen plug is a little bit more difficult to use. I usually like to use a non-resorbable membrane, and then I will suture the membrane together with the soft tissue, so it holds it in place. It doesn't move. Remember, immobilization of the graft is extremely important. What is your opinion of using? Next question, what is your opinion of using PRF with socket preservation? PRF is excellent. I don't dislike it. I used to use it quite a bit. Only thing is now I don't use PRF because I use something different, and I think it's even better, and it's called BioExclude. And we can do a webinar on that if you're into that. Going to the next question, can you use the ice cream cone technique if we have a case where both the buccal and lingual bone is compromised? 100% absolutely yes. Because what the ice cream cone technique is to allow you to basically create an artificial wall to secure the bone graft until the bone graft solidify and basically convert into the patient's bone. So absolutely, basically wherever you have the defect, it is recommended. And then I believe this question is, what will you use if you are grafting a site for a bridge that you don't want any resorption in the future? Xenograft. Xenograft basically it's a volume space maintainer. If you're not going to be placing implant, I have no problem using animal bone. It will work very, very nicely to keep the shape. From the chat room, another question is, would you be able to get the recording? I'm not sure. I think you have to ask our host, Young, for that. We are in the process of publishing video on the website, and will you be able to do those? Sure, we can always talk. But I think that's it with all the questions. Thank you, Doc, for coming, and hope to see you guys very soon, and stay safe and healthy, and take care. Young, I think we're all set. I think all the questions are done. Can you take over now?
Thank you, great, Doctor. I think we have just 2 more questions that's coming
we
up
do?
through the Q&A. Yes.
Okay. I see it down here. Question, when would you consider using larger allograft particle size, like 1,000 or 2,000? You know, that's a great question. I'm not comfortable using a larger size. That's just me. I like to use smaller size because the smaller size gives me more surface area in contact with the blood. And by having more blood coating onto these granules, these allograft granules or particles, in my mind, it's going to help convert it faster. And in some cases, it might be a little bit difficult to use because these granules are smaller. But I find that if the clotting factor is pretty normal with the patient, it's pretty straightforward. And then the last question, if you have two or one wall defect, do you use tenting screw for grafting? Again, that is your choice. We talked about the ice cream cone, Dr. Tarnoff technique. Tinting screw works extremely well, but if you're going to be using that, that means you have to create, open up the flap, and then more suturing and basically a more invasive procedure. But will it work? Absolutely. That basically is you're getting into the major GBR. And that's something we will be actually talking about later next month, if you're interested. Okay, Young, am I done? I think I got everything, right? Oh, I got one more. If bone fragment from extraction, would you crush it and use it as graft material? You know, done that many times. I totally agree with you, Doc. I would use it. Why not? It's the patient's own bone. As long as it's clean, it's good, and you can crush it and make it into fine particle, more power to you. I think it's great because you know the body's not going to reject that. Thank you, everybody. Stay safe. Hope to see you guys soon.
Look like we answered all your questions. And Dr. Chen, is there anything else you would like to mention?
No, I think this is it. I think this is as much time what we have, unless there's more question. But in general, I think socket preservation is something that we can do for our office. And it's good for the patient. And if we explain to the patient, the main thing it's about bone loss and soft tissue loss. And the soft tissue loss is they don't understand what attached gingiva is. They just know hard gum, soft gum. The hard gum that is necessary to support your teeth, your crown, your implant, your denture, everything. You need that. When you have bone loss, that soft tissue goes with it. It goes hands in hand. So it's important that they understand that. And also, if you don't do anything, that bone loss over time, it's just going to expand more and more and more, and it will start to shift the teeth because it's an empty space. So your occlusion, it just leads to everything. I think everybody understands that. But most importantly, with doctors, is we got to explain that to the patient. And when I do my public seminar, I choose one topic, and that's bone loss. Patient understand bone loss. They're willing to do what's necessary to preserve the bone, knowing that if I keep the bone, I'll keep the soft tissue, I'll keep the foundation, and aesthetically everything is maintained, and function-wise everything's maintained. So something very simple can protect a lot of things in the mouth. So with that being said, I think that's it.
All right, thank you, doctor. Thank you very much for your presentation. And now I want to make important announcement. So if you are interested in taking our webinars, you can find upcoming webinars in our website at www.neobiotech.usa.com and click on this webinar at the top and you'll be on our webinar page. So, and starting on next week, we will have 2 webinars on every Mondays and Thursdays. So total 4 webinars weekly, and the day is every Mondays and Thursday, 1 in the morning from 11 to 2, and the other one is in the afternoon from 2 to 3 p.m. It's Pacific Coast time. And we have a great lecture coming up soon on Monday, May 4th at 11 a.m. and also 2 p.m. on the same day with Dr. Jason Kim about hard and soft tissue conservations and simplifying the grafting procedures. And also on Thursday, May 7th at 2 p.m. with Dr. Spencer Parr about implant stability. And here's more other webinars. You can find it on our website, on our webinar page. The first one is on Monday, May 18th at 11 with Dr. Mike Chang on ridge splitting. And then the next one is on Thursday on May 21st with Dr. Owen Chen on All Next. And lastly, on Thursday, on May 28th at 2 p.m. with Dr. Mike Chang again on the reach augmentation with GBR. So save the dates in your calendar because you don't want to miss it out. And thank you very much again for stay until the end and joining this webinar. And as part of our ongoing effort to provide better continuing education courses, we would like to request your feedback via a short course evaluation. And one of our sales rep will email you the link to complete the course evaluation form. So once you receive it, please fill it out and submit it as soon as possible because you will receive your CE upon completion of this form. And this form should take no longer than 5 minutes to complete. It's very simple. It's very simple and easy. And that form should look like this, and there should be more questions in the bottom. And thank you again for participating in today's webinar. And we really hope to see you again next time. And please feel free to contact me if you have any further questions. Here is my email, ayong.chui@neobiotech.usa.com. And thank you again and have a wonderful day. And thank you, Dr. Chen. Thank you, Dr. Chen again.
Thank you, everybody.
Thank you. And I hope all of you have a good rest of your day. Thank you.